Good evening, dear colleagues, and welcome to this popular live webinar on highlights of EuroEcho, organized by the European Association of Cardiovascular Imaging. My name is Bogdan Popescu. I work in Bucharest, Romania. I'm the EACVI president, and I have the pleasure to share this evening with my friend, my colleague and friend, Professor Erwan Donal, who works in Rennes, in France, and who is vice president of our association, being the chair of the ECHO section. As you know, the topic of the day is discussing the highlights of the last EuroEcho that was last December in Leipzig. This is a very interactive event, supposedly, so we kindly ask you to put your questions and try to interact in order to get full benefit of this educational program. Of note, we will not be able to take all the questions probably because there will be many, but in any case, the questions that we cannot answer tonight will be answered in the coming period, so it is really worth interacting. Just a few words about the EACVI. The association is increasing in membership, especially after its formation from the EAE with the two working groups on CMR and CT nuclear. And we reached this last year a record number of members of more than 8,600. So there is a great interest, and coming back to our topic, EuroImaging 2016 was a successful congress. We had as main themes imaging in arrhythmias and aortic valve diseases, and you can see here the congress in a few key numbers. We had a large number of sessions in 4 days. We had hands-on sessions, we had imaging campus, we had, of course, satellite symposia, a large number of faculty people, outstanding scientists from many countries. We are very proud that our Congress is very prominent in terms of presenting original investigations, so we had a very large number of abstracts submitted that were peer-reviewed blindly, and we were able to put forward some of the good work that was submitted and that we will going to present tonight together with Erwan. A lot of countries were represented, and this was a big congress. A particular thank you to the Scientific Program Committee, composed of a large number of colleagues and friends, outstanding scientists. In particular, I would like to thank Professor Bernard Cozins and Dr. Julien Magne, who had a central role in putting together the program in a big team, and also the local hosts had an important role in making this event a success. In terms of participants, as you can see, we were again above 3,200 participants, which is more or less in the line with the previous congresses. So again, a large number, making this one of the key events in cardiology. We had delegates from many countries. Again, the large countries with many EACVI members were also the ones that attended most, as you can see in this list, including some countries from Eastern Europe, Leipzig not being so far, and these countries being also more and more active in the past years. I would again stress the fact that we had many abstracts submitted from many countries, from all continents. We had also abstracts from the United States, from Asia, apart from, of course, our member countries of the ESC. The way we thought to organize this webinar together with Professor Donal is that we chose four main topics that we're going to discuss. He's going to present the main studies that were shown in Leipzig, and after each of these parts we're going to stop for about 5 minutes to take your questions and to discuss the interesting ones. So again, before giving the floor to Erwan, please ask your questions and try to interact as much as possible. My pleasure now to introduce Professor Erwan, who is going to present the first main topic.
Thank you very much, Bogdan. Thank you. It's a real pleasure for me to be here today to discuss with you some of the abstracts that have been presented during this meeting. We are very proud of this meeting because there is a lot of innovation that have been presenting during this meeting. So first, we will start with a chapter about innovations and imaging. So we will discuss few abstracts that have been presenting. First, I want to share with you this abstract. This is a French abstract. This is the first study performed in men looking for myocardial stiffness using the shear wave generation and the ultrafast imaging. This is a sort of dream to be able to assess non-invasively the myocardial stiffness. And for the first time, this team coming from Paris was able to measure the myocardial stiffness with this ultrafast imaging technology. They did this study in normal subjects and patients with hypertrophic cardiomyopathy and heart failure with preserved ejection fraction. And as you can see, they were able to demonstrate that they can distinguish the normal myocardium from the myocardium that is too stiff, the myocardium that is the myocardium from the hypertrophic cardiomyopathy. So this is a beautiful study about the assessment, the non-invasive assessment of myocardial stiffness using ultrafast imaging. So this is something very important, and we have a lot of expectation with this new technology. Second, I want to discuss with you the potential value of the study of Vortex. Vortex is something that we can measure nowadays using transthoracic echocardiography, and it has been performed in a population of patients with dilated cardiomyopathy. This Japanese study is a very good study because they were able to measure the vorticity all over the cardiac cycle. And they measure the global vorticity of the left ventricle. And as you can see, they were able to observe some kind of very interesting pattern, interesting vorticity during the isovolumetric contraction period. And in that study, these Japanese authors were able to demonstrate that if the vorticity during the isovolumetric contraction period is lower than 14, then the prognosis of the patient is much worse than if the vorticity is preserved. And as you can see in that multivariate analysis, the vorticity is an independent prognostic marker in this population of patients with dilated cardiomyopathy. So really, we have now two new parameters that can be measured by transthoracic echocardiography, and these two parameters, stiffness and vorticity, seems to provide something new and probably very interesting for the assessment of our heart failure patients. I want also to discuss something about heart valve disease, and this is a very beautiful study that has been performed in Belgium. This is a study trying to develop a numerical model of the mitral valve apparatus using the 3D transesophageal echocardiography. And in that study, the authors evaluate the potential clinical value of this modeling of the secondary mitral regurgitation. So they started from the 3D transesophageal echocardiography, and they were able to provide a finite element geometric model of the mitral valve. You have here the model, the dynamic simulation of a secondary mitral regurgitation. So this model is beautiful. Is it useful? Is it close to the reality? They check for that in patients, and they were able to demonstrate that what can be done with the model is very, very close to the reality. It means that you can use the model to predict the impact of a treatment, maybe, in patients with secondary mitral regurg. And you can see that the predicting volume is closely related to the effective regurgitant orifice area. So it means that you can use this model, this 3D model, to understand better what happened in a patient with a secondary mitral regurg. This is very, very interesting and very, very promising. And I want also to discuss something that is not echocardiography, because you know that we are moving to imaging techniques. We are not using only echo in any single patient. We use echo first mainly, but we use also other imaging modalities. And in that study, the goal was to check for the necessity to revascularize a patient with a coronary artery disease. And this beautiful study performed in Spain looked at the value of the CT, the perfusion CT, associated to the angiography performed by CT. So the authors compare the CT angiography with the CT angiography plus the CT perfusion. So they do a CT angiography after having using esmolol to slow down the heart rate. So they did a CT angiography that we are using in the daily clinical practice, and then they use also dipyridamole to do a CT perfusion. And they were able to demonstrate that dipyridamole rest stress CT angiography plus CT perfusion showed high diagnostic accuracy and increased the CT angiography alone positive predictive value for the assessment of obstructive coronary artery disease. So this new tool combining two modalities of the CT seems very, very promising to best send patients for a coronary angiography when they need a revascularization. So this is the 4 abstracts that I would like to discuss now about innovation in the field of imaging, and mainly, of course, in the field of echocardiography.
Thank you. Thank you very much, Erwan. I think that was very interesting indeed. And as we can see, a lot of new things are presented during EuroEcho, the potential applications of which are to be discussed, of course. And maybe if we can just put together, because from those that you presented, it seems there is an interest in looking novel ways of looking at myocardial function. The first abstract that you presented about myocardial stiffness, and the other one looking at vortex formation. What is your view about the future use of such novel parameters, and how would they be applied? In which type of pathology do you see a particular use for those new techniques?
Yes, thank you, Bogdan, for that question. I think it's quite interesting to see that we are using LV ejection fraction for a while, and most of our clinical decisions are based on LV ejection fraction. But nowadays, and still I will say nowadays, there are many teams amongst us trying to find new tools to best assess LV systolic function and also RV systolic function. Of course, there are beautiful studies. There are a lot of expectation when we think about cardiac MR. There are also expectations using nuclear imaging, but you can see in the abstract that I showed that even if you consider transthoracic echocardiography, we have new tools. This assessment of stiffness, this is quite powerful, very interesting to best assess patients with hypertrophic cardiomyopathy, to best assess fibrosis also. So this is very promising. The Vorticity, this is something we are discussing for a while, but it seems that nowadays, with the new technology that we have, we can assess Vorticity quite easily by transthoracic echocardiography. And I didn't show other abstracts that have been presented. For instance, we have a lot of expectation with the assessment of cardiac work, because we know nowadays that we can use transthoracic echocardiography, we can combine speckle tracking and pressure to measure cardiac work, non-invasive cardiac work, which is something that we were dreaming for many, many years. So we really have many studies to perform to demonstrate that maybe we can change our mind, moving from ejection fraction to something else, or maybe to combine ejection fraction with something else to best characterize the function of our patients.
Thank you very much. I think that is very promising indeed. Of course, we need to see how these parameters perform in terms of reproducibility, not less accuracy. And there were questions here related to even how strain echocardiography is performing if we think of variability both between operators and also between vendors. Would you comment on that?
Yes, I think we can comment on that. I think that you have to know the paper that have been published by Jan Suver Voigt about the task force from the American side and the European side of the imaging societies. And in that study, using all the echo machines, it has been demonstrated that GLS, global longitudinal strain, is more robust, more reproducible than E/A ratio, that the measurement of the diameter of the LV in M mode. So I think it's very important to know that if you are well taught to use this technique, you can use speckle tracking in your daily clinical practice. And I have to confess that in my lab, in the lab where I work, we are using GLS all the time. We are using GLS because it's useful to best assess the function of our patient, but also it's a way to make sure that when we measure ejection fraction, we are not doing something wrong, because it's more difficult to measure ejection fraction than GLS. So we have really to push forward for the use of GLS.
It seems that there is big hope with the further development and refining of this use, and I think also the learning curve is an important feature. People need to know how to use these new techniques if they are to apply them properly.
And you know that with the EACVI, we are doing a lot, we are pushing a lot for more teaching courses to teach all of you, all of us, how to use these new technologies, because these technologies are not that difficult to use and we have to implement them in our daily clinical practice.
As long as you know how to use them, and we encourage you to participate in the tutorials and in the other events that we organize. I suggest we move to the second topic now.
Yes, let's move to the heart failure. Heart failure is a big, big topic, and I selected few abstracts that I've been presenting. The first is something that is not very innovative, but it's very important that you keep in mind this approach. Because in the cardiology field, we are not using the B lines as we should, I think. And that study was performed in Pisa, in Italy. This is a very beautiful study. So first of all, you have to keep in mind that using ultrasound techniques, measuring comets or B lines, it seems very useful, very practical, and it's a very simple way to directly image the extravascular lung water. It has been demonstrated for a while, and it's not used in many labs, which is a pity. Recently, there was a clinical update paper in the European Heart Journal highlighting this fact, underscoring this fact. B-line can be evaluated anywhere, anytime, by anyone, even cardiologist, I will say. It can measure at baseline, but it can also be measured during an exercise, which is very interesting for the cardiology community. And the study that we want to discuss today is a study that is comparing the value of the assessment of B-line at rest and the assessment of these B-lines during an exercise in a population of heart failure patients. And that study was performed in a quite large number of patients, and as you can see, the number of B-line greater than 30 is associated with the prognosis of patients with heart failure when you assess the presence of B-lines at rest. But it's even more powerful if you use this assessment of B-line during a submaximal exercise stress test. So you do an exercise echo, you check for the heart, but you check also for the lung, and then you can have a new parameter that is very powerful to predict the risk of death and the risk of hospitalization for heart failure in your heart failure population. And as you can see, there is an additive prognostic value in this assessment of B-lines at rest, but even more during an exercise. It's better, it's in addition to BNP, it's in addition to the peak VO2, so it's a very powerful tool that you can easily implement in your echo lab to best assess your patient with heart failure. The second study that I want to discuss, it's not a study about echo, but it's also a comparison between echo, speckle tracking longitudinal strain, and the technetium scintigraphy that we are used to do to perform in patients with transthyretin amyloidosis. This is a French study, and the authors looked at their patients by transthoracic echocardiography. They look for the speckle tracking and they look for the GLS, and you can see this pattern, very typical pattern of transthyretin amyloidosis with a preserved longitudinal deformation of the apex and a severely decreased deformation of the basal segments. So you have this typical pattern of longitudinal deformation that is related to amyloidosis. And they perform also technetium scintigraphy, and they compare the data they have by echo and the semi-quantitative analysis of the heart retention of the tracer during this scintigraphy. And they were able to demonstrate that there is a correlation between GLS and the semi-quantitative assessment of the captation of the tracer by the heart. And there is no correlation between the LV ejection fraction and this captation by the heart of the tracer, which means that the relationship between the captation of the tracer and the LV function is better assessed by the GLS than by the ejection fraction. This is another proof that we have to implement GLS in our daily clinical practice. So this is a nice study emphasizing the fact that GLS is something that can be used in clinical practice and is very powerful to detect patients that have transthyretin amyloidosis. So that's it for heart failure. Maybe we can discuss a bit about all the abstracts that have been presented in that field.
I think that indeed heart failure was one of the major topics in terms of submissions, as well as valvular heart disease. These are usually come on top of the list when in terms of numbers of submissions. It's a lot of interest in this field. So I think that one of the nice points of those studies that you've shown is that, so on one hand we have very novel tools, very sophisticated, very advanced, that we discussed in the first part. On the other hand, you can see that even with something as simple as putting a transducer on the posterior thorax of the patient, so something that everyone has at hand, you still can get very important information that is incremental in value to the standard information and to even sophisticated like the VO2 consumptions. And also that by combining parameters, that each of them assesses different links of the pathophysiological path, you can get, of course, a better overall assessment. So I think that we have to look both at the most advanced things and to test them properly before applying them, but at the same time not forget to use what we have and what is probably underused, like this simple technique of lung comets. I would just make one point. We will try to develop in this regard and to assist non-cardiologists that want to use ultrasound for cardiological assessment by developing a package, a product on focus echocardiography that would allow people to really use echo in the point of care to best manage the patients.
Maybe I can comment a bit.
Please.
We are not that old, but when we were students, we learned that heart failure was a clinical syndrome. But we know from the recent guidelines, from the recent ESC guidelines, that nowadays heart failure is not a clinical syndrome anymore. It's a clinical syndrome and an imaging syndrome. We need imaging techniques to best assess patients with heart failure. We know that we have heart failure with preserved ejection fraction, mildly reduced ejection fraction, and reduced ejection fraction. So we need echo, CMR, and other imaging techniques to best assess patients with heart failure. So we have a lot to do with imaging techniques using CMR, which is not available for everybody. But just as you said, looking at the B lines, we can do better than just using our stethoscope. So it's very important for the young community, but not only for the young community, to keep in mind that using the transducer, we can improve the way we assess heart failure patients.
I fully agree, and I also think imaging is fundamental to managing patients with a suspicion of heart failure, not least because it can provide, unlike the other tests, the cause of heart failure, without which we cannot properly take therapeutic decisions. Because you brought this into discussion, HFpEF is an important topic, and we had many questions here related to the diastolic function assessment, the recent recommendation that were launched by EACVI and ASC, and for example, a question about the prognostic value of diastolic function parameters. Would you comment on how we could assess this?
This is an important question. Maybe a whole webinar is necessary to discuss that. But this new recommendation paper is better than the previous one, obviously. It's a good one, but still there is a problem because we have not enough data to demonstrate that what is proposed is valid, is associated with the prognosis. So we have to apply this new recommendation in cohorts to demonstrate that they are useful. It's not done yet. Also, we know that we learned for a while that E over E prime is a very strong parameter that we have to assess in our patient with diastolic heart failure. But this was based on very few studies performed mainly in the single center studies with a very few patients, always with the same teams involved. So it's not good enough. And thanks to the EACVI, thanks to the Committee Research on Innovation, we were able to perform a study, the EuroFeeling study, and that study will be published soon. And it is the first time that it was possible to conduct prospectively a multi-center study comparing the CAT and the echo, the assessment of E over E prime, but also the other diastolic parameters, to demonstrate that they are useful, that they are associated with the CAT results, and hopefully that they are associated with the prognosis. But today, we cannot answer to that question. We still have a lot of work to do.
Yes, I think that's an important point and also related to some other questions. So I will stress that we need validation of the algorithms proposed. However, it is clear that no single parameter can give us the answer, and we need to combine a multi-parameter approach. And the new thing that the new edition highlights is the role of stress diastology, because often we forgot that these patients have symptoms during exercise, and we keep on assessing them during resting conditions, which is not the same. And it has been shown that adding stress diastology on top of the resting examination increases the accuracy of making the HFpEF diagnosis. There is another question here about the B lines, whether these may appear even when the clinical symptoms are weak. Would you comment a little bit on the quantification of these B lines?
So that's true that I can use the clinical practice that we have in my institution. We are used to look for B line when we want to let a patient go home. The patient is hospitalized for heart failure. We treat the patient, and as soon as we decide that he can discharge, we check for the B line, and if there is more than 30 B lines, then it means that still the patient is congestive, so we have to increase the furosemide dosage, and then we keep the patient in the hospital. So this is more powerful than the clinical assessment of congestion. This is the key point. Assessing B line is more powerful than the clinical exam.
There is another question with relation to cardiotoxicity and the way of assessing cardiac function in patients who are undergoing treatment for cancer. Would you comment on that?
This is
quite a big one.
This is a difficult topic, but this is the same. We need to have more data, and thanks to Patricio Lancelotti and Maurizio Galderisi, there is the COT registry looking at breast cancer and the consequences of the treatment of the breast cancer on the heart. So this registry is going on, and you can join if you want. This is important to best understand what's going on. But if we want to assess the consequences of the chemotherapy on the heart, we have to look for the ejection fraction, but ejection fraction is not that robust. So also, again, we have to use the GLS, and a decrease in GLS greater than 15% means that there is a consequence of the chemotherapy on the heart, and it might change the way you treat the patient. So first, you have to collaborate with the oncologists. You have to see the patient before the treatment and during the treatment. And according to the result of the echo and the imaging modalities you use, you can discuss with the oncologist to best treat the patient, to change maybe the way you treat the patients. So this is still an ongoing project because we need data, but already we can say that ejection fraction is not enough. We have to implement GLS in our daily clinical practice. And we have to collaborate with oncologists to be more powerful and to best treat our patients.
Thank you, Erwan. Another question relates to the diagnosis of myocarditis, whether and how we should complement, whether using imaging of which sort or endomyocardial biopsy. What is the role of imaging in making this? This is another one.
I think that really CMR is a great tool, and we have to use CMR in this indication. This is something that is much more powerful than the other imaging techniques, and nowadays we cannot make the diagnosis of myocarditis without CMR. Of course we can do the biopsy, but the biopsy will just take a small part of the heart and not maybe in the good position. So we really have to do a CMR. This is mandatory. And then maybe sometimes you have to do a biopsy to check for the etiology of the myocarditis. But first, start with the CMR. It's very important.
Agree on that, definitely. I think that we should now move to the third topic. Please present the arrhythmias.
Yes, thank you. So you know that the Leipzig meeting was mainly based on the assessment of heart valve disease, aortic valve stenosis, but also we wanted to discuss a bit the role of imaging in the field of arrhythmias. And I selected two very beautiful abstracts about the role of imaging techniques in the field of arrhythmias. And first of all, I want to discuss the importance of strain, again, in the field of arrhythmic right ventricular cardiomyopathies, because we still don't know. Is the arrhythmic right ventricular cardiomyopathies a disease starting by an electrical abnormality, or is it a disease where the myocardium is sick before that appear the electrical abnormalities? We still really don't know. So this team coming from Netherlands was able to use imaging techniques and mathematical modeling to best understand what happened in patients with arrhythmic right ventricular cardiomyopathies. So they did a beautiful clinical and mathematical modeling study. They started with 84 desmosomal mutation carriers. So these patients have the disease. They are a carrier of the mutation. But some of them, according to the last task force, have the disease, have the clinical expression of the disease or not. And they were able, looking at the strain at the basal segment of the free right ventricular, at the free wall of the right ventricle, to show that there are three patterns. First patterns is the normal one, the type 1. You see you have a normal deformation of the basal segment of the free wall of the right ventricle. This is what we are supposed to see in a patient without any right heart dysfunction, without any right heart abnormality. This is the type 1. The type 2, you see you have a decrease in a systolic peak of strain, and you have a delay onset of shortening. So a delay onset of shortening and a decrease in the peak. And afterwards, you have a post-systolic shortening. So this is type 2. Delayed onset of shortening, decrease in peak of systole, and post-systolic shortening. Type 3, you have an absence of systolic peak of positive deformation, and you have a huge post-systolic shortening. This is the type 3. So this is the three patterns that you can observe in the right ventricle when you assess patient with right ventricular dysplasia, but also patient without this kind of disease. And when you look at the population they have, you have here the patient that have the subclinical stage of the disease. So they have the mutation, but they have no disease. The ECG is normal, the alter ECG is normal, the patient is totally asymptomatic. And when you look at the CMR, when you look at the echo, you have no abnormality of the right ventricle, nothing. But when you look at the longitudinal strain, you see that half of the population have the type 2. It means that in half of the population, you have a decrease in the peak of systolic deformation and you have some kind of post-systolic shortening. When you have the patient that have the stage of the electrical disease, so the EKG is abnormal, you see that most of them have the type 2 and some of them are type 3. And of course, when you have the structural stage of the disease, then most of the patients are type 3, some of them are still type 2, but of course, the right ventricle is sick, so you can see by strain, but also by CMR on normal echo, that the right ventricle is sick. But keep in mind that here you have the capability using the strain imaging to show that in patients that are completely asymptomatic, you have an abnormal systolic function of the right ventricle. And thanks to the mathematical simulation, it was possible to demonstrate that this abnormal strain pattern was not related at all to any electrical abnormality. It was related to a decrease in right ventricular systolic function and to an increase in RV free wall stiffness. So really, we can say after that study that the right ventricular dysplasia, the right ventricular cardiomyopathy, is first a disease of the myocardium and then a disease, an electrical disease. But first, this is a disease of the myocardium. So this is really a cardiomyopathy. So it has been demonstrated by that study, and it has been very recently published in JACC. So this is a very, very beautiful study conducted by this great team in Netherlands. The second study that I want to discuss is named How Many Are Too Many? This is quite interesting and original because we know that a lot of patients come to visit cardiologists because of PVCs. Most of these patients have nothing wrong. Actually, they have some PVCs. They feel these PVCs, but they have no cardiomyopathies, they have no ischemic heart disease, no valvular heart disease, nothing. But in some cases, the frequency of PVCs might be linked to the presence of LV dysfunction. And according to what we know, it is written in the literature that as soon as you have more than 24% of PVCs over the 24 hours, then you can observe a reduce in LV ejection fraction. That means that if you have 24% of PVCs over 24 hours, you developed a LV dysfunction, so you develop a heart disease, so you might require a treatment, a pharmacological treatment, or maybe an ablation. But you have to wait for 24% of PVCs before proposing this kind of treatments, which is not that convenient. And that beautiful study that has been performed in Oslo, in Tore Edvardsen and Christina Oga team, use GLS to check for the consequences of PVCs on the LV function. So they looked at the frequency of PVCs on EKG alters, and they look at LV ejection fraction and GLS by transthoracic echocardiography. They consider that GLS is abnormal if the GLS is higher than minus 18%. And they were able to demonstrate that there is a correlation between the frequency of PVCs and the GLS, the decrease in GLS. Which is interesting is that there is no significant relationship between the percentage of PVCs and the ejection fraction. that is quite interesting. And they were able to demonstrate that as soon as you have 8% of PVCs over 24 hours, you have a decrease in GLS. So it means that as soon as you observe 8% of PVCs, you develop a LV dysfunction that might require a treatment, a pharmacological treatment or an ablation. So using GLS instead of LV ejection fraction, they were able to demonstrate that you might be able to propose a treatment as soon as you have 8% of PVCs instead of 24% of PVCs. So this is quite interesting to use these imaging techniques to best decide to propose a treatment or not in patients with PVCs coming from the right ventricle. So this is quite interesting for our clinical practice, and I think that you might have comment on that.
Great. I think that this is a really innovative field, because one wouldn't really expect imaging to play such an important role in patients with arrhythmias. Yet, with the new methods, we see increasing use of echo from making the diagnosis, as we saw in entities that this is not really easy to do, like the arrhythmogenic right ventricular cardiomyopathy, looking into the cause of the disease and then into risk stratification. The mechanical dispersion was shown to be of important use in different types of cardiomyopathy, in coronary artery disease, in electrical diseases, laminopathies, etc. Yet another use of GLS, as you saw and we discussed before. And again, we will have another webinar on strain later this year, so stay connected to the EACVI webinars. There is a question here about the possible role. You addressed it to some extent, but if you want to comment more, how can methods of imaging, including newer methods, be used to find the origin of ventricular arrhythmias, if there is any possibility, and what would you comment on that?
This is an interesting question. I think that we can predict the risk of arrhythmias, or we might be able to predict the risk of arrhythmias using the dispersion of the peaks of the longitudinal strain. It has been demonstrated in laminopathy, as you said. It has been demonstrated in ischemic heart disease. So we can predict the risk of severe arrhythmias. Can we predict that the arrhythmias are coming from that part of the heart instead of that one? I think using transthoracic echocardiography, it's too early. It might be the case in the future, but up to now, it's too challenging, I think, or I guess. For that purpose, I think we have to combine the electrical mapping of the heart and the CMR or the CT, but also maybe the ICE catheter might be used, because you know that there is a technique using the ICE catheter. You put the ICE catheter in the LV, and combining the electrical mapping and the ICE catheter, you can have a global map of what happened in the heart, in the left heart, and then you can best assess where the PVCs are coming and where you have to ablate the patient. So up to now, I think echo is good to predict, might be good to predict, but we have to demonstrate that better than we did in larger series. And there is a study going on thanks to Thor Edvardsen and thanks to the EACVI, which is the IMPROVE study, looking for the value of dispersion of longitudinal strain in the field of heart failure to predict the risk of arrhythmias. To answer to the question, where are the PVCs coming from? I think it is too early to use transthoracic echocardiography.
Yeah, I agree with that. I think it's too much to ask for this. And finally, there is one other question of clinical relevance, obviously. How can we assess in which way viability by strain echo or by speckle tracking, actually?
Viability, we can assess viability if we use low-dose dobutamine stress echo and GLS. So this is something we can do. The level of evidence is not that high also. And for the future, for the fellows that are listening to this webinar, I think you have to keep in mind this new tool that we discussed earlier, the cardiac work, because when you use the cardiac work, you check for the viability, you check for the capability of the myocardium to work better. So up to now, we have few studies showing that using strain and low-dose dobutamine, we can best assess the viability. We can assess the viability. But we can do better with new tools like the cardiac work. And of course, because echo is something, but echo is not alone, CMR is very powerful. And of course, nuclear imaging is a key tool to use when we want to assess viability. So CMR, CT, not CT, PET and TEP can be used, but strain is also something that is valuable.
And combining the techniques
maybe
may improve.
Yes, because sometimes it's very challenging.
Yes.
For instance, in my lab, I used to combine stress echocardiography and CMR because we are not used to use PET in our daily clinical practice.
Thank you, Erwan. I suggest we move to the last part of our presentation.
Yes, it's an important part because, as you know, imaging people like valvular heart disease, and there were a lot of abstract, a lot of new studies performed in that field during the meeting. So we selected with Bogdan few studies. The first one is quite original. It's coming from Belgium. It's coming from the Bernard Cousin's lab. So this is a beautiful study. This study comes from a large amount of work because this team worked first in the animal lab. They were able to demonstrate that the concept is valid, and then they apply the concept in the clinical practice. So the idea was that in our daily clinical practice, when we assess a patient with an aortic valve stenosis, we have sometimes, or very frequently, to measure the amount of calcification of the aortic valve. This is quite relevant, and this is especially relevant when you have a patient with a low flow, low gradient, preserved EF aortic valve stenosis. So the assessment of the degree of calcification of the aortic valve is something that is useful, and this is something that is in the guidelines. So we have to assess this amount of calcification. So up to now, we use CT for that because it's quite convenient, but this is still something using CT, so using irradiations. So the idea was to not use CT, but to use echo and to try to quantify the amount of calcification of the aortic valve using the video intensity of the aortic valve by transthoracic echocardiography. So as I said, this Belgium team did a validation study in the animal lab. They were able to demonstrate that they can quantify the amount of calcification of the aortic valve in animals. And then now they present a study using this tool in the clinical field. So for that purpose, they standardized the way they put the region of interest in the transthoracic echoes to measure the amount of calcification of the aortic valve. So as you can see, they use the parasternal long axis view, and they defined the region of interest they want to measure the degree of calcification of the aortic valve. And they use also the parasternal short axis view to get the global calcification score of the aortic valve. So this is quite simple. They developed a software to do that, and they were able to demonstrate that there is a quite good correlation between the assessment of the degree of calcification of the aortic valve with CT and the video intensity of the aortic valve by transthoracic echocardiography. So this is a nice study providing us the demonstration that maybe in the future we will use only echo to quantify the degree of calcification of the aortic valve instead of combining the assessment of the aortic valve by echo for the hemodynamic and the use of CT for the calcification. So great expectation in the assessment of the degree of calcification of the aortic valve thanks to echo, and thanks to this team for doing this study. The second study that we can discuss is about the tricuspid valve. We don't know much about the tricuspid valve, the tricuspid regurgitation. And this study was performed in Padua. And you know that in Padua, they are doing a lot about the assessment of the right ventricle, the right heart. And they know how to manage to use 3D echocardiography in the field of the right ventricle. So they did a beautiful study. And as you can see, they compare patients with a right ventricular volume overload, with patients with a right ventricular pressure overload, with patients with atrial fibrillation, and they have 21 healthy volunteers as a control group. They did an assessment of the right ventricle using the 3D assessment of the right ventricle. They did the same for the right atrium, and they measure very precisely the tricuspid annulus. And as you can see, they were able to demonstrate that the main determinant of the size of the tricuspid annulus is not the right ventricle, this is the right atrial maximal volume. So they were able to demonstrate that the tricuspid annulus size is mainly driven by the size of the right atrium and not the right ventricle. Let's move on now to a CMR study, a beautiful CMR study about bicuspid aortic valve stenosis. And as you can see, they were able to measure the wall shear stress of the ascending aorta in patients with bicuspid aortic valve. And as you know, there are different kinds of aortic valve, the bicuspid aortic valve, and they compare these different kinds of bicuspid aortic valve according to the impact of the bicuspid valve stenosis on the aorta. And you see that they use these CMR techniques in 86 patients, and they compare the behavior of the flow in the ascending aorta in patients with a right-left fusion phenotype with a population of right non-coronary fusion phenotype. And they were able to demonstrate that the consequences of the bicuspid valve phenotype is very different on the ascending aorta behavior. And they were able to demonstrate that when you have a fusion between the right and the left cusp, you have a jet mainly towards the right wall of the ascending aorta. When you have the second phenotype with a right non-coronary fusion bicuspid aortic valve stenosis, you have a predominant posterior orientation of the jet. And this has consequences on the stress of the aorta and the morphology of the aorta. So this tool, this CMR tool, is very powerful to understand the morphology of the ascending aorta, to understand why the dilatation is not homogeneous according to the phenotype of the bicuspid valve. We don't have much time, but I want to finish with this beautiful study that we were able to conduct thanks to the Committee Research and Innovation of the European Association for Cardiovascular Imaging. So this is a study that we perform with Julien Magne and all the association about the importance of global longitudinal strain in patients with asymptomatic significant aortic valve stenosis. This is an IPD meta-analysis. We were in contact with all the investigators who publish in that field. So we were able to discuss with 10 authors, and we were able to get the data from 237 patients. So we combined the data from all these studies to try to see if GLS is something that is useful in the field of asymptomatic severe aortic valve stenosis. And quickly, we were able to demonstrate that GLS is a strong prognostic marker in patients with severe asymptomatic aortic valve stenosis. This is an independent prognostic marker, a very strong prognostic marker, even when you adjust for the effective aortic valve area, you see that still the power of the GLS is very strong. So you can keep in mind that with a cutoff value of minus 13%, we were able to distinguish two different populations, patients with a high risk of death with patients with a small risk of death. So GLS seems to be very powerful to predict the risk of death in patients with asymptomatic severe aortic valve stenosis. And you can see that as soon as you have a GLS greater than 13%, you increase your risk of death by 4. So you have a 4-fold increase risk of mortality if your GLS is decreased and you have a severe asymptomatic aortic valve stenosis. So this is quite an important result that we were able to get thanks to the association, thanks to all of you, thanks to the energy that we put in this association, and we think that it might change the way we image patients and the way we deal with our patients in our daily clinical practice. So thank you, it's the end for me, and we can still discuss a bit. And of course, you will have to come next year to the next EuroEcho-Imaging in Lisbon. Thank you very much.
Thank you, everyone. That was very nice. And again, I'm sure that there were many other worthy abstracts that could not be included, but for the sake of time, of course, we need to choose. And I think that we shouldn't go on without thanking the colleagues that presented the works and the colleagues that summarized the works during the highlight session of EuroEcho: Julien Magne, Luigi Badano, Bernard Cousins, yourself, Chiara Bucciarelli, Alessia Gimelli, and Owen Miller, because they kindly shared their presentations with us and we were able to make another selection. Just briefly coming back to the issue of valve disease, so I think that this is an important study that you showed from Belgium, and I would like to ask you about the use of ultrasound in quantifying calcification of the aortic valve, because we know this is important both diagnostically and prognostically. CT is gold standard as we know it. Of course, it has some caveats like radiation risk and so on. Do you think that in future this could further develop and could replace to some extent the other methods in assessing calcifications of the valve?
I think that we have the paper from Raphael Rozenek a few years ago, published in New England Journal of Medicine, demonstrating that if we use a semi-quantitative approach and transthoracic echocardiography, we can predict the risk of event in patients according to the degree of calcification of the valve. Nowadays, CT is quite popular and easy to do. It's quite convenient, as I have to say. But of course, if we can do like we do with CT, just with a transthoracic echo, it might be better. And I think this is something that we have to keep in mind, because the work performed in the Bernard Cousins lab seems very promising, and I know other teams working on 3D transthoracic echocardiography, and they have the same kind of results. So I think that in the future, we might go back to echo instead of moving forward to CT, and just assess patients with echo when they have a severe aortic valve stenosis. And I think we can have a great expectation in the fact that we will be able to quantify the calcification of the valve soon.
The potential is there.
Yes.
The other thing was interesting, of course, this tricuspid valve in the right heart, usually difficult to assess by conventional techniques unless you employ some sort of three-dimensional imaging because of the shape of this part. And also to see that usually the annulus that we believe dilates with the ventricle, in fact, it's very much related to the size of the right atrium. And these things may open up a new understanding of how this secondary TR develop, for instance, in patients with atrial fibrillation. So I think that it may bring some new information important for the practical management. Would you comment shortly on that?
Yes, I think this is of great clinical value, because we have a lot of difficulties with this kind of patients, and I think that we have to learn from Luigi Badano lab, because they know how to use these techniques. They use this technique in our daily practice. So if they can do it, we should be able to do it also. So we still have to learn how to use imaging techniques, CMR, CT, nuclear imaging, but also echo, because we can do better than we are doing.
Thank you very much, Erwan. I think it's time for us to close, and I would like to thank again Erwan and to all the people that have contributed. I think this was a successful Congress. In fact, the survey after the Congress show that most of the people were satisfied with the overall quality of the Congress. I invite all of you to join the EACVI. It has a big range of benefits in the membership. Come to our courses, attend the webinars. There's great educational values in it. You can sit an exam to test your knowledge and to get a valuable confirmation. And of course, come to the Congress. We will have next year EuroEcho, in fact this year, this December, in Lisbon. Erwan is chairing the program together with Thor Edvardsen. Imaging in heart failure and interventional imaging, another big topic that we are sure you're going to like. So stay close to the EACVI. Thank you very much and have a good evening.